This is Barbara Cochran from the Deterioration Center for Healthy Aging and representing the Northwest Geriatrics Workforce Enhancement Center, which is sponsoring this lecture series. And just a few reminders if you haven't filled out a profile page from your site coordinator, please ask them for one. Keep on sending those evaluations into your site coordinators. And if you want continuing education contact hours, let your site coordinator know. There's a sheet that tells you how to access the continuing education site and sign up for those. Today we're very happy to have Dr. Lianne Hirano. She completed her fellowship in geriatric medicine at the University of Washington, and she's a board-certified geriatrician in palliative medicine attending at Harborview Medical Center in Seattle. Through her experience working with families at Harborview and out in the community, she's had the privilege of interacting with many patients and caregivers. And today she's going to be talking about caring for the caregiver. So welcome, Dr. Hirano.
Thank you. Okay. So I can just get started.
Oh yeah,
great. Okay, and I'm just gonna. You can see my pointer, right? No. Okay, I'm so sorry. Is there a pointer?
There's not. Do you need one?
I'll probably be okay without one.
Okay.
Okay.
There is something we can do if you need.
Okay.
Sorry. With the arrow, you can
okay.
drag this around.
Okay, great.
And they can see that.
Yes.
Okay, thank you.
Yeah.
Thanks, Grace.
Sorry about that.
Okay, thank you. Okay, so I'm just going to jump right in here, and I think Heather got the slides out to the sites, and I think you guys saw that I have a lot of slides, but caring for the caregiver is definitely complicated. What I'm going to try to get through is caregivers. Who are they? We can talk a little bit about what the caregiving workforce in America looks like right now, what challenges our caregivers face, how to care for the caregiver, which is the meat of this talk. And of course, because I'm a palliative care provider, I do want to touch on some good tools and communication strategies that might be helpful in caring for our caregivers. And then I do want to touch on a topic that I feel I did not get a lot of good training on. I think if there are any social workers out there, you guys get much more and better training than I ever got in grief and bereavement. And I would suspect from my nursing colleagues as well that maybe our educational systems are lacking in that area. I don't think I actually ever formally got any education on grief and bereavement when I was in medical school or residency. So I would like to just touch on that. So a lot of information. The slides, you have them. So hopefully if I breeze over anything, you will have the details in your hands. Again, caring for the caregiver is very challenging. I don't feel like there are any easy answers. I am not here to offer easy answers or simple solutions. I'm hoping to give you some tools that might help, but there are no one-size-fits-all tools for caring for our caregivers, as many of you already know. And not all of the tools that I'm going to give you might be the right ones for the job that you are doing out in your communities. I'm hoping to give you some ideas because maybe some of these ideas can generate discussion in your communities, and they can be starting points for programs that you can put together yourselves. And then the bottom line is just that caring for our caregivers really does take a village, sort of like raising a child. It's interdisciplinary, it's specialized and individualized care. And I think it takes innovation and motivated folks like you out in the communities. Okay, so that being said, I did run across this interesting article after I turned in my slides, but it's about this really neat project in North Dakota, and I don't know if you guys can see it on the screen, but it's a statewide project that they started through the Alzheimer's Association and with some grant funding, but it's really focusing on the caregivers. And so as opposed to some of the other programs that people have started, out in various communities trying to care for individuals with dementia. This program actually focuses on the caregiver as opposed to the individual with dementia. And it's had some really surprising and very encouraging results. So I encourage you all to maybe Google it and take a look. But I will absolutely do that. I think it's really great. So they said that, you know, the purpose was to help families keep loved ones at home, and the caregivers felt more empowered. The number of hospitalizations and ED visits went down, and there was a decreased amount of facility placement for the patients. It saved about $800,000 on hospitalization costs, is what they're estimating, and about $39 million in long-term care costs. And for those who are here, I am going to just pass that around so you can take a look at that. Okay. Oh, there we go. So caregivers, generally, for the purpose of this talk, I'm going to refer to caregivers as those folks who are the unpaid individuals involved in assisting folks with dementia and with their care needs. So things like ADLs, basic activities of daily living, and also the intrinsic activities of daily living and medical tasks. So estimated in the US, this is from a study done in 2015 from the National Alliance for Caregiving and the AARP, and I tried to look for more recent data. But 2015 is kind of the most recent large-scale inventory. So about 43.5 million caregivers in the U.S. That's a lot, and 34.2 million caring for someone greater than or equal to 50 years old. So the majority of caregivers are women. 60%, and 85% of our caregivers are caring for a relative. And throughout this talk, I found this wonderful New York Times article by Paula Spann following this woman, Elizabeth Wolfe, who actually runs a blog, Upside Down Daughter, I want to say, Living with the Parents I'm Losing to Alzheimer's, that I thought was very relevant to a lot, and illustrates a lot of what I'm going to be talking about. Okay, so caregiver challenges. Parent care continues to be the primary caregiving situation for our midlife caregivers, with 70% of caregivers in middle age, between the ages of 50 to 64. And this is my dad and my stepmom, and I thought they kind of illustrated that idea well. Lynn, my stepmom, is caring for her 91-year-old mother, who is in turn caring for her equally elderly sister. The older our caregivers tend to be, the more hours they tend to dedicate to caregiving, and that's just what this graph illustrates. Many caregivers of older people are themselves elderly, which of course presents a number of challenges. Caregivers are actually increasingly older. So back in 2004, the average age of our caregivers was 46, and now it's about 50. So the percentage of caregivers caring for individuals 85 years and older has definitely increased. However, I think now what we're also seeing is that a quarter of our caregivers are actually millennials, and they tend to be equally likely to be male or female. Our caregivers, as you know, face a lot of challenges. Not a surprise that a big challenge that they face are financial and economic challenges. The more time spent caring for a loved one, the less time you can spend going to work. And so caregivers often have to pull back on the number of hours they're working or quit their jobs altogether, therefore giving up health insurance, wages, and other job benefits like retirement or savings. And I found this next statistic just really depressing and frightening, that single women caring for an elderly parent are 2.5 times more likely than non-caregivers to live in poverty when they themselves get old. And I just find that really sad. So just a lot of financial burden for our caregivers. And I think, another statistic that I found that I thought was also just incredibly surprising is that family caregivers, being unpaid, their economic value of their care for the loved ones that they're providing is actually estimated to be at about $470 billion a year. So that's roughly the spending of Medicaid in a year. So back to the New York Times story. In 2010, Elizabeth Wolfe, then 30, was living in Vermont working for a nonprofit, and she was exploring new pursuits and had some fun hobbies, and then received some phone calls about her parents, Louis and Nancy Brood. They were living in New Jersey, and she was living in Vermont, and we'll talk about kind of that geographic separation between caregivers and care receivers. She expected to arrange caregiving help and then return to Vermont with her husband, but 5 years later, she's still in New Jersey caring for her 81-year-old father and 65-year-old mother who both have dementia. And there's the link to her blog. It's upsidedowndaughter.com, so I highly recommend checking that out to get kind of the inside scoop on one caregiver's experience. So other economic challenges to caregiving, this I thought was rather interesting as well. So a recent report from the National Academies of Sciences, Engineering, and Medicine suggests that our reliance on this caregiving workforce is definitely not sustainable. So currently, we have about 7 potential caregivers for every 1 person over the age of 80. And that's what that top illustration represents. And the demand for caregivers, unfortunately, is increasing, but our supply of caregivers is unfortunately shrinking. And as you can imagine, as medical care becomes more complex and we get better at keeping people alive for longer, we have more elderly, right? We always talk about the silver tsunami coming. While our caregivers, a lot of us are, not marrying, having smaller families, and living in a different state than our parents. And so they estimate by the year 2050, we'll have less than 3 caregivers for every person over the age of 80. So other challenges for our caregivers, they tend to not take care of themselves very well, right? And they undergo a lot of stress and their health suffers while they're providing health care and care for their care recipient. Again, a lot of our caregivers are older, so they themselves are pretty frail and could also even be disabled. They tend to put their care recipients' health care needs before their own. Sort of the opposite of putting the oxygen mask on yourself first. They tend to put the resources towards their care recipient and minimize their own healthcare needs. So of course their mortality and morbidity risk is higher. And then compared to non-caregivers, caregivers who provide care specifically to a spouse with dementia, you can see just have a lot more health challenges themselves, and they have more illnesses than non-caregivers. They have poorer immune responses to vaccines. They have slower wound healing, which is incredible. A lot of these things associated with stress and an inflammatory, kind of chronic inflammatory response to stress and depression. And they've actually studied this in caregivers who have a spouse with dementia, and they have these increased levels of inflammatory cytokines like IL-6 and increased levels of CRP. And these increased levels of these inflammatory markers persist for, they've found 3 years after their spouse has died. So they're not just at risk during the time that they're caregiving, but this persists for several years even after their spouse dies. So back to Elizabeth Wolfe, she says, most of my me time is spent going to the gym. I see a therapist and get acupuncture a couple times a month too. These are the things I do to stay alive. More than anything, the grief or loss I feel is in the form of loneliness, the isolation. I don't know how to relate to people my age. So I really like her quote of, these are the things I do to stay alive. They're not the things that she does to remain healthy or, remain, or to de-stress. They're critical things that she does to stay alive. Okay. So that leads me to the emotional and psychological challenges of being a caregiver, which I think most of you are very familiar with, but our caregivers are, of course, at higher risk of depression. They're twice as likely to be taking a psychotropic medication. Really kind of frightening statistics. They have 4 times higher stress symptoms than the general population. So we're really at risk. So caregiver factors that are associated with a higher risk of depression are the ones that I've listed here from this article by Schultz and colleagues. So imagine an older female spouse with maybe not very good coping abilities, a very poor social support system, who's been caring for her husband for a really long time. On the flip side of that, patient factors or care receiver factors that are associated with an increased risk of caregiver depression are the ones listed here, and I think you can recognize them as being basically a lot of the symptoms that we find or factors that we see in advanced dementia. So dementia and loss of function, more reliance on their caregiver to help with activities of daily living and basic care. Caregiving is hard, but dementia caregiving in particular is harder. I'm just going to get rid of this arrow here because I'm not using it. I know there's a lot of words on this slide, so I'm going to let you read it at your leisure, but basically it's all the things that you can think of that go into dementia caregiving, that it's more disruptive to family and life. It has an even higher risk of negative mental health impact on the caregiver. You have less time for yourself to do the things that you used to do, even just spending time with family and friends. I think no surprises there. And then just some other factors in determining caregiver stress. Again, no surprises. There's some intrinsic caregiver factors that help or hurt coping strategies. Personality, right? Some things that we can't change personality, some things that we can maybe help with or modify, like coping strategies. And then, what was their relationship like before their loved one had dementia or was diagnosed with dementia? And of course, economic and social supports are huge. So Elizabeth Wolfe says, once in a while, I let myself think about what I've given up. Casey and I decided not to have children, but I feel like a mother to my parents. I value the incredible intimacy I get to share with them. When I was a teenager, my mother was pretty critical. She ignored me for days at a time. I think she was overwhelmed by motherhood. Now, this role that we share, it's changed the dynamic, the history of our relationship. However, many years down the line, looking back, I'll think of the moments of tenderness I shared with her every single day. Which leads me to caregiving isn't all bad, right? Some people derive a lot of pride, a lot of satisfaction, and that there are some rewards to caregiving. So about 1/3 of our caregivers will report that they don't have any stress or strain, no negative health effects, especially early on, before I think people have the symptoms of really advanced dementia. People can derive a lot of satisfaction and meaning making, like I think you saw Elizabeth Wolfe was doing in that excerpt. Some folks can have increased self-esteem. They're learning a new job, they're learning a new role. It's almost new identity, so it impacts a lot of very personal sense of self, and that can, for about a third of folks, be really beneficial. Okay, so let's talk a little bit about what caregivers are facing. And this slide talks about specific caregiver tasks that they might have to take on. Basically, it's a job, right? You have to learn a whole new skill set, as in any job that you're going into. And some of the skills that you need to learn, giving medications, using medical equipment, managing finances for some people who maybe the primary person managing finances was their husband, and now they're left with trying to figure out the banking and the checkbook. And that could be something new for them. Caregiving is complicated and dynamic, especially in dementia, where people are losing function throughout the course of the illness. So it's a decline, and there are transition points that I think we can talk more about and intervene on. But at each transition point, I think the caregiver sometimes needs to learn new skills. So we have to help figure out what new tools we can help them with. Caregivers who have access to education about these skills report lower levels of stress and lower levels of burden and less distress as well in caring for their care recipients. Okay, so more about some potential needs that we can anticipate. Folks want more information about services. They might possibly benefit from some information about stress management and coping strategies, help with financial issues, help with communicating with us, because we speak a different language. Medicine can sometimes be a different language. Healthcare can be a different language. Disease information can be a different language. They need help finding competent helpers who can help them care for their loved ones. And they need help learning how to perform kind of the basic care tasks as well. I think we can help with all of those things. So one thing that I'd like to propose that I haven't seen a whole lot of research on, but that I think might be an interesting thing to explore is anticipatory guidance, the idea of anticipatory guidance. And it's something that came up. I have 2 young children, and I think a lot of the pediatricians talk about this. So if you're a family provider or family practice provider, you know a little bit about this. But the medical definition is proactive, developmentally based counseling technique that focuses on the needs of a child at each stage of life, right? Anticipating what the transition points will be and then providing guidance about that. So can this model be used to provide our caregivers with anticipatory guidance for our patients with dementia, for their care recipients? And I would argue that we know some of the transition points in Alzheimer's. I know dementia is complicated, and there's definitely a lot of individual variability. But there are some things that I think we can agree on. This is the global deterioration scale. I think a lot of you have seen it before. It talks about the different stages. People generally tend to get diagnosed and recognized by the medical system at about stage 3 to 4, where there's mild to moderate decline, where memory loss becomes noticeable, not just to the family and not just to the patient, but more noticeable to the folks around them, to the point where people will bring it to the attention of a medical provider or to family. So some of the transition points that can be sort of extrapolated from the GDS, and I think just in general, sort of thinking about dementia, are the ones that I've sort of highlighted here. And you guys might have different transition points, but I think these are some of the ones that I've encountered in my practice, and hopefully you guys have seen as well. But definitely the initial diagnosis of dementia, and then that advanced planning stage for healthcare and financial needs, Safety ends up coming up, particularly around driving. I think that's something that is a real touch point for families, when to take the keys away. Managing behavioral symptoms is definitely a big transition point that I see in practice. Changes in care settings, so that can be from hospital to facility, home to hospital, home to facility, and then eventually end-of-life care, because recognizing dementia as a terminal illness is definitely important. So I'm just going to go through those different transition points and touch on some ways that we might think about guiding our caregivers at each transition point. And I left out a lot of detail because I think a lot of this care is very personalized and very individualized. And again, I don't have easy answers. It's just really to kind of get you guys thinking about chances and transition points that we can kind of capture our caregivers and provide them with tools. So initial diagnosis, of course, this represents the entry into that caregiving role, getting that new job, if you will. And I would say that grief and bereavement almost starts here, right? You're coping with the idea of the loss of the person that you know, loss of memory, loss of ability to care for oneself. So a lot of loss, the patient might be coping with that loss as well, depending on how good their insight is. And then Elizabeth Wolf touched on this. Caregiving is lonely, so there's feelings of isolation because maybe you're the only one who has a family member with dementia. Chances are you're not, but for a lot of our younger caregivers, you might be the only one with a loved one with dementia who you're caring for. And again, that takes away from your time with friends and your support system. So what can we do at this point? Well, hopefully we're already doing this, providing some information on dementia and its trajectory and prognosis. I am almost embarrassed to share that I realized that my mom did not recognize dementia as a terminal illness. We were having a conversation about one of my grandmother's friends who had dementia, and my mom was so horrified and surprised that she could no longer talk or feed herself or go to the bathroom on her own. And I was like, what did you think dementia was? So failing on my part as a geriatrician who has a mother who didn't know that dementia was a terminal illness, what the end stages of dementia look like. That's a lot of people, right? Because if you look at how dementia is portrayed in the media, in our movies, a lot of times we see dementia portrayed as memory loss, but we don't see the end stages of dementia portrayed in popular media. So I won't be too hard on myself. Other potential resources, it's good to identify whether or not the caregiver has good social support themselves, or if they could benefit from support groups, online resources. The Alzheimer's Association has amazing online resources. There's a lot of support groups that occur online as well. So principles of caregiver assessment, I kind of threw this in here. This might be a good time again to just figure out how much does our caregiver know and what are their resources, because you don't know what you don't know. And our caregivers, this is a new world opening up for them. So they're, we don't know where they're starting from. And if we can kind of get a sense of where they're starting from, we can meet them where they're at and put other support systems in place that might be helpful. Again, as I've already mentioned, there's a lot of competing demands to our caregivers' time. People are starting out at different knowledge levels, different skill set levels. They have different capabilities. Some people might have family nearby that can help and jump in. Other people, it might just be them, and that's it. They have themselves. Okay, so the second transition point that I think generally tends to come shortly after the diagnosis is that planning stage that I mentioned before. And this is planning both financially and medically, right? Because again, I think a lot of people don't necessarily know what the course of dementia looks like. And this might be a time to sort of talk about that. Finances, I can't underestimate the importance of addressing this early on. If you think of America, a lot of people in America think that Medicare will pay for us at the end of our lives to live somewhere, to get placed somewhere, and that they will not have to bear the burden of that cost. But as we all know, that is not true. Medicare does not pay for that. It's a lot of out-of-pocket costs. That's why medical bankruptcy is the #1 cause of personal bankruptcy in the United States. So financial costs to the caregiver, as I mentioned before, loss of jobs, loss of wages, they start having to pay for more out-of-pocket medical expenses, and that can be a huge burden. And then the patient themselves at some point will also lose the ability to manage their own finances, right? So that loss of financial capacity. And that's actually one of the first instrumental activities of daily living that people lose. So what can we do? So definitely mentioning that and guiding our caregivers, letting them know that, you know, proactive financial planning might be a good idea. And then because I work in palliative care, I think what is also a little distressing is the low rates at which people fill out advanced care directives or living wills, and the low rates at which they designate surrogate decision makers, even when they have these diagnoses of dementia. So we definitely need to get better at doing some of this work up front, because we'd like to have these goals of care discussions, advanced care planning discussions, when the patient themselves or the care recipient themselves can still participate in some of these discussions. That takes the burden off of the caregiver of having to make some of these harder decisions further along down the line when your patient can no longer make the decisions for themselves. Okay. Another transition point, safety. And I know this is a really hot button topic for a lot of people because driving, what a challenge, right? I think I have had just so many patients and families who have struggled with taking the keys away, when to take the keys away, how to do it in a manner that doesn't upset their care recipient or their spouse. And it's challenging. I definitely don't have any easy answers. I think it depends a lot on these creative, individualized solutions. I think guns is another hot button topic because there was recently a story that came out about someone with dementia shooting family members. So, you know, safety, I think taking away the keys, taking away ammunition. I will readily admit that I practice medicine in liberal Seattle, so those of you who are out in more rural communities probably have much more creative and better, frankly, ways of finding a solution to some of these safety issues. Cooking is another one that comes up a lot, where we will often tell families, you know, you might want to think about taking the knobs off of the stove, so that nobody turns on the stove and leaves it on while you're out at work, and you come home to find that your house is burned down. Medication management, again, one of those activities of daily living that tends to be lost early on. Providing Medisets, caregiver teaching on how to administer injections, and other things. Okay. Another transition point that I think is really tricky and challenging are behavioral symptoms. Wandering, insomnia, agitation, aggression, delusions. I would argue that insomnia is probably the easiest one of those to treat because we have a lot of pharmacologic measures to treat that. The wandering, the agitation, the aggression, delusions we're not quite as good at. However, again, like I said, no easy answers, creative, individualized approaches, community resources. I think the North Dakota article has a lot of great little tricks that I think a lot of you already know and already tell your caregivers. Things like, you know, if your patient with dementia brings up a spouse who's died or somebody who's died that they love, we don't have to keep reminding them that that person is dead, right? There are ways that we can distract them. So an example is, you know, one of my patients would ask her son, "Oh, where's daddy?" Meaning her husband. He hasn't been around in a while. What's he up to? Why isn't he here? Why isn't he with us at this doctor's appointment? And her son would tell her every time, "Oh, dad's dead, Mom, don't you remember?" And so we talked about, and of course she would, you know, it would be shocking. It would be terrible. It would be devastating, and she'd re-grieve right there all over again. And so I think a lot of you know this trick of saying, "Oh, yeah, I miss dad too. Do you remember the time when," and you tell a funny story, and it's a distraction technique, right? So we have a lot of those tricks. And I think if we can give those tools to our caregivers, especially early on, and give them tools to anticipate some of these things, that's incredibly helpful and powerful. Okay. So changes in care setting, another transition point, and like I mentioned before, there's several different transitions in environment, right? So when someone becomes too hard to care for at home, we often see them ending up in a facility when the wandering and the aggression and delusions become too much to be managed pharmacologically or at home. We often find ourselves entertaining the idea of whether or not this person is needing to be placed in a higher level of care. So by age 80, approximately 75% of people with dementia will require nursing home care. And the majority of people with dementia, 90%, will require nursing home placement at some point in their illness. It's not the only place that people end up. Sometimes people end up in the facility and then go back to the hospital and then come back to the facility, or of course, you know, they can end their life in the hospital. So hospital transfers are actually quite common, unfortunately, in the final 6 months of life in a lot of our advanced dementia patients. And as you can imagine, I think Medicare is taking a really close look at that and would like that to change. No easy answers again. I think as far as anticipatory guidance, we can let people know that there is an adjustment period to any change in environment. And it often, unfortunately, manifests itself as delirium and sundowning, so behaviors might get worse. I think as physicians, we sometimes tend to give that 6-week recommendation. So any transition in environment will take about 6 weeks for someone with dementia to get used to. So warning people that there might be an adjustment period to a new environment that takes that long. It takes a while. I often encourage time trials. So if somebody's maybe not sure about whether or not placing their loved one in a facility is right for them, you can consider a time trial. And what that often looks like is using your respite benefit and allowing a trial to see if that's the right direction to go in. So Elizabeth Wolf says, there was a point in May of 2013, we'd been here 2.5 years when we had plans to move my parents into a facility. We were going to do a respite stay, and if they fit in, if it went well, we'd sell the house. We did everything we could. We brought couches and furniture from their bedroom to make the place feel home-like, but it wasn't home. For my dad, it lasted 3 days. He started having panic attacks to the point where he was throwing up. He was still with it enough to call us. I remember getting a message from him weeping, "It's Daddy, please, me and Mom want to come home." Everybody, including his doctor, said, you have to leave him, you have to let him adjust. I couldn't do it. I would never judge the people who do, but I couldn't. They've been here 40 years. All my dad ever wanted was this home. Who am I if I take my dad from his home? So it doesn't always work out, right? We have to meet caregivers where they're at. One size does not fit all. Placement isn't right for everyone. It's complicated. So the last transition point I wanted to talk about was the end-of-life care and beyond. And by beyond, I mean the grief and bereavement, which we'll also talk about. But again, recognizing that dementia is a terminal illness. The 6-month mortality for patients who develop eating problems, things like dysphagia, pneumonia, especially aspiration pneumonia or febrile illness, is 40 to 45%, it's about half. So I will be talking about palliative care and grief and bereavement. So for now, let's talk about things that we can do to help serve our caregivers throughout the course of dementia across the continuum. This is Patty Davis. She's the daughter of Nancy and Ronald Reagan. So she served as a caregiver for her dad when he developed dementia. And I want to read a quote from her from this article titled, "You're taking care of someone with Alzheimer's, but who is taking care of you?" So Patty says, people come to the support group for the first time and they're armed with all these facts about their mother or their father. They say they're on this medication, they were diagnosed on this date, and their doctors say this and that. And then I say to them, how are you doing? And there's this moment where they have to process the question, and almost inevitably, that's when the tears come. It might be the first time in a year or more or ever that they've been asked, but how are you doing? So what can we do throughout the course of dementia? And I think that Patty Davis's quote brings up a really important point, that I think a lot of you are already doing this work. But the first point I want to make is just ask, right? Just ask, how are you doing? Ask our caregivers how they're doing. As Carol Cummett, who's a social worker for UW Palliative Care, likes to say, this is not chit-chat. This is actually powerful work that you are doing and that you can do anytime to help our caregivers. So I think these are things that you're actually doing. I want you to recognize them, though, as work, that you are helping your caregiver or serving your caregivers when you ask them how they're doing. Listen and reflect, be present with them, acknowledge their emotions. And what I like to do is normalize. That's okay to feel the way that they're feeling. If they're feeling angry, that's a normal reaction to the challenging situation they find themselves in. Just to take that a little further, be sensitive to cultural, religious beliefs, age differences, empathize with your caregivers. Something that I always keep in mind when I'm going into a palliative care conference is to understand where I stand, knowing my own biases and trying to leave them at the door when I'm serving our families in the hospital, and keeping my own biases in check. Can be really difficult, but very beneficial to our caregivers when we leave our ideas at the door. And when we recognize our own limits on our knowledge and when to refer to our consulting providers, our social workers, our colleagues, our interdisciplinary team. Again, it takes a village. Not all of our caregivers are necessarily ready to accept support, so we have to be aware of that as well. It doesn't mean that you ever have to stop offering or stop reminding people what resources are there, but don't be surprised if your offer of resources or help is initially rejected or resisted. I think a lot of us can recognize that there are several phases to caregiver acceptance of support, and recognizing the need for help is just the first step. And that's often the biggest hurdle to get over for caregivers, is for them to recognize that they need help. The second really big hurdle that I've seen people struggle with is giving themselves permission to actually have someone help them. So giving yourself permission to actually obtain that help. So how do we identify caregivers who are at risk, right? Because I've mentioned that there are a lot of things that caregivers are at risk for: depression, illness, stress, financial burden. And so there are caregiver self-assessment questionnaires out there. I like this one that I found on the AMA website, and the link is there on the slide. I like it because it's short and it's a self-evaluation. So the caregiver can score it themselves, or you can score it, or your office staff can score it. When I had my first child, I went to the pediatrician's office, and while I was waiting for the visit, the appointment, they gave me an iPad, and I had to fill out basically a caregiver self-assessment questionnaire, I think, to see if I was suffering from postpartum depression or was at risk of hurting my children. But it looked very similar to this, and it didn't take very long, and I handed it back to the receptionist when I went in for my visit, and I'm sure they scored it and made sure that I was not at risk of harming anyone, but a good one. And then our caregivers have different ways of coping with different situations. There are some healthy ways of coping, and there's some not quite as healthy ways of coping. So kind of recognizing where our caregiver is at can also kind of help figure out how much at risk they are and how they're doing. So least healthy are the people that we see who are avoiding the situation. So what we often think of as denial, wishful thinking. Slightly better is living one day at a time. I hear that a lot on palliative care. I'm just taking it one day at a time. And I think that's fine. People, again, have different ways of coping. And then the healthiest coping strategy out there that we see in our folks is problem solving, mutual support, acceptance, being able to refrain, being able to do some meaning making, sort of like what you were seeing Elizabeth Wolf doing with the new relationship she had with her mother. So nothing new here. Evaluate and treat the caregiver and the care recipient as a unit. They're a team. Treat your caregiver as a member of the healthcare team. Treating them at the same time during office visits is often synergistic. The usual promoting self-care, downtime, facilitating communication, and joint problem solving. Again, I don't think these are new ideas for any of you. So I like to think about communication as a palliative care provider because there's so much misunderstanding and lack of communication out there in the medical world. We speak a different language, and you're not just communicating now with your patient, you're communicating with your patient who has some cognitive dysfunction, and you're communicating with their caregiver who's also highly emotionally invested in this situation, right? So problem areas or sticky areas for us often include the diagnosis itself, prognosticating around that diagnosis. Prognosis in general is an area that we're not so good in. Decision making, I will give you some tools for that because I think we can definitely help in that area and do a good job, and care preferences. Again, communication. I want to encourage trying to get that advanced care planning done. And again, like I touched on previously, attention to grief and bereavement, showing empathy. I'll go into detail on all these things. So communication. You can consider obtaining some training in palliative care. A lot of our palliative care education nowadays focuses on communication and advanced care planning. That's sort of where the field is going. Caroline Hurd has developed a graduate certificate course in palliative care. The faculty are excellent. I think it's 9 months, and you get a certificate at the end. There's also a 2-day palliative care course, not course, but conference that UW puts on. It's actually occurring right now. It was yesterday and today, and it was all about advanced care planning and communication. So there are opportunities out there. I think there might be online opportunities as well, but keep your eyes and ears open for those opportunities in your communities. Families want providers to be comfortable discussing death and dying. They want us to be able to discuss some of these uncomfortable topics with them clearly and in a timely fashion. Remarkably, there is not a lot of research that has been done about doing advanced care planning early in the course of dementia, mainly because we just haven't. We don't do it. We don't do advanced care planning early in the course of dementia when our patients can still help us with it. So that's an area where, if you're interested in research, is wide open. Okay. Talk less, listen more. Listen and express empathy. So again, listen, listen, listen. Careful listening reduces risk of caregiver depression. This has been studied. The sources are documented below. I just included some of the actual words and phrases in this article because I like, as a palliative care provider, I like actually being given the words to use, because when I have an actual question to ask or sentence to use in the back of my head, it comes out a lot easier than when I'm making things up on my own. So how have things been going for you and your family? Really simple, right? But it's nice to have that in the back of your head. This must be a difficult time for you. How can I help? Tell me what's upsetting you the most. And then I can't I can't overemphasize this enough, but even just bearing witness to suffering and even just being present with your caregiver and listening to them is work and is an amazing thing that you can do for your caregivers. I know we can't necessarily bill for it, but I think it's something that is so powerful that, again, you know, you heard Elizabeth Wolfe mention the isolation, the loneliness. I think that's a lot of what our caregivers are facing out there. Empathy, reflection, and validation. Again, a lot of the tools that we use in palliative care practice. Assessing family dynamics and caregiver emotions, right? There's, you know, you're just seeing a snapshot of this lifetime of God knows what lies beneath the surface of some of these scary family dynamics that we're witness to. And that can be, frankly, just incredibly challenging, right? Because people have very different personalities and can have very extreme personalities, and that can present extreme challenges to how we try to help serve our caregivers and their loved ones. I really like this tool of normalizing, so recognizing certain emotions and then validating that that's an okay, common feeling to have, especially when you're in the challenging situation that a lot of our caregivers are in, and then reassuring the caregivers that they're providing good care. I use that a lot in practice as well, because I think when you're doing such hard work and it's very personal work and you're giving so much of yourself, to have that acknowledged that you're doing a good job. No one else is necessarily telling these people, hey, you're doing a really great job caring for your loved one. So they don't even have that kind of positive enforcement that some of us get in our job. They don't get that. You can be the one to provide that. So I'm going to go through the discussing goals of care pretty quickly, because I think you actually have someone else who's talking about palliative care. But this is just a framework, and you can go through these slides in a slightly slower fashion at your leisure. But really, it's the basics of palliative care. This is Tony Bach's ask, tell, ask model. Where you're kind of assessing the knowledge, trying to figure out what the caregiver understands, where they're at right now, and then filling in any holes or details that might help them understand the situation better or bring them up to speed while avoiding medical jargon, responding to emotion. asking if it's okay to talk about prognosis and what the future will look like, doing some of that anticipatory guidance. And I'm sorry, and then determining if the patient has had these discussions before. Have you had someone else in your family with dementia? Has your loved one seen anybody else suffering from dementia? What did they think about that? Did they talk to you about that? Okay. Again, we're just trying to get to know people better, what their strengths and supports are, both the patient and the caregiver. What are their hopes? What are their fears and concerns, both the patient and the caregiver? And then one of the things that we like to touch on is, would there be any circumstance in which you would find life not worth living? I know that's a heavy question to ask people, but it can be built into some of these conversations and not seem quite so awkward when you throw it out there if you're having this type of conversation. Again, prior experience with illness and hospitalization can tell you a lot about where they're starting from. And then I always like to ask about surrogate decision maker. If you were to get so ill that we couldn't talk directly, who would you trust to be involved with your medical decisions? And then code status, of course. Always good to touch on. Consider what level of decision or control the patient or caregiver might want or need. And don't be afraid to make recommendations, right? When I was in medical school, I think the pendulum had swung all the way over to autonomy, and the way I was taught to have these conversations was to give the patient and family member a menu of choices, and my job as the provider was to educate them as best I could on each choice, and then to let them choose. And I was not to offer my opinion on anything. It was now in their hands to make that decision. And I think, that our pendulum swung that way because back in the 50s and 60s, right, it was more parental. And now I think what we're doing is swinging more towards the middle, where we have this model of shared decision making that Randy Curtis developed for the ICU, but I would argue that we can use in a lot of different discussions that we have with patients and families, because really you are the experts in what this type of treatment and care looks like and what dementia looks like. And the patient and family are the experts in themselves and what their values and goals are. And if we can determine what the patient and family's values and goals are, we can then tailor their medical care and match their medical care to the values and goals. We talk about goal concordant care and palliative care, matching the treatment to the patient's values and goals. Okay, so shared decision making as a tool. Again, as I mentioned, focus on known facts about the patient's values and preferences. We try to have our families use substituted judgment. So if you're having this conversation late in the stage of dementia, encouraging the family member to try to use substituted judgment can sometimes help when they're feeling at a loss. And then offering guidance, again, like I said, in specific situations, which we know that the outcomes will not be necessarily what the family or patient has in mind for their goal. Again, it's a dynamic and ongoing process, subject to change. So it's not set in stone, and it might change along the way. So in my last 15 minutes or so, I do want to talk about grief and bereavement and touch on that, because again, it's a topic that I did not get a lot of education on when I was in medical school or as a resident or even as a fellow. So it's something that I've worked on a little with Carol Cummett, who's one of the social workers at UW on the palliative care service. So when our patients die, what do we do? A condolence phone call, letter, visit, attending the patient's funeral. I think we've all done that. Providing family with information about the grief process are all things that we can potentially do. What is grief and bereavement? Bereavement is the reaction to the loss of a close relationship. Grief is the emotional response caused by a loss, including pain, distress, and physical and emotional suffering. I think we're all familiar with this. Most folks out in the world are familiar with this because it's Elizabeth Kubler-Ross's model of the stages of the grief cycle, and it's often touched on in popular media as well. But we all sort of know that, at the beginning, prior to the loss, you have this sort of normal functioning period, and then you go through the various stages of the grief cycle: shock and denial, anger, depression, detachment, dialogue, and bargaining, acceptance. And then the idea, and not necessarily Elizabeth Kubler-Ross's idea, but I think the idea that we've all kind of come to be familiar with, at least from the popular media treatment of Elizabeth Kubler-Ross's stages of the grief cycle, is that you come out at the end and there's this return to sort of meaningful normal life. So what is normal grief? Grief takes many forms, but don't worry, we're here to help you fill them out. So one of the, and now not so new theories, and I think a lot of you in social work will recognize this as a not so new theory, but to me, as a medical provider, I was like blown away by this, are the grief, tasks, and loss theory of William Worden. And this might not fit our caregivers. I'm just going to put that out up front because dementia is a very complicated grief and loss, protracted journey, right? Caregivers and patients themselves may be experiencing losses throughout the course of this illness, different losses on practically a daily basis, right? You're losing your memories, you're losing your function, you're losing your ability, to do things that you used to be able to do. You're losing interests that you had in certain hobbies that you can no longer do. So it's this prolonged period of cumulative loss. So how do you grieve? How do you grieve that, right? So I will talk a little bit about William Worden's grief, task, and loss theory because, again, when I heard about this, I thought this was so much more useful to me as a provider when talking to my patients and families about grief and loss than the Elizabeth Kubler-Ross 5 stages. So the first step is acknowledge the reality of the loss, or the first task, I should say, is acknowledging the reality of the loss. And that's a really tough task, right? To actually accept that you have had a loss. There's a lot of shock, numbness, and we often throw out the word denial, but I think Carol likes to tell me that true denial is actually quite rare. It's really the shock and numbness that we're being witness to, and not true denial. And we're witnessing people doing the work, right? We're witnessing people doing the work of acknowledging the reality of the loss, and that can look to us like denial. Okay. So the second task is experiencing the pain. So actually like going through the pain of grief and loss. And that one's hard too, letting yourself go through that pain, because part of what we like to do, and part of our protective nature is to move away from going through pain. So again, this could be manifest as emotional, physical, social, spiritual, financial, all of the above pain. But that's another task that William Worden argues that you have to go through. The third task is adjusting to an environment in which the deceased is missing. So learning to go on with your life in the sense of learning to go on with being able to eat, sleep, breathe, in a world where your loved one is not there. And the final task is reinvesting emotional energy and remembering the relationship. So this idea of continuing bonds, so not going through something and letting go and forgetting the person, but learning to live in an environment where the loved one isn't there, but finding a way to continue that relationship, to renegotiate that relationship in a meaningful way that will sustain you for the rest of your life. So those are the 4 tasks. And again, I think, this refers to the loss of a loved one, but it can also refer to any type of loss. So Carol likes to talk to me about, it can refer to the loss of, your function. So in spinal cord injury victims, the loss of that independence that they have. But again, dementia is just very complicated because it's this, again, cumulative loss throughout the course of illness. Very complex. Okay, so is there life after caregiving? So there's this period, I think, where there is such a thing as the aftermath of caregiving and transitioning from this role that you have played or role that you have fulfilled at times for years, and figuring out, it's almost like the third and fourth task that William Worden lays out, but transitioning to this new identity. Who are you if you're not a caregiver? It's very complicated. It can look different for different people. I'm just going to kind of breeze through these because I think you guys have seen how people react to grief and loss, and there's different domains. You can read through that. I do want to pause on this slide, though. Carol Kamen and I have talked about helping versus fixing versus serving. So I think when I started off in medicine, I definitely saw myself as a helper, right? I'm going to help my patients. I'm going to help their families. But Carol would argue that this sees the other person as weak and the helper is strong. The helper has all the power. So it's talking about these power relationships that we have. That perhaps a better way of seeing our relationship with our caregivers and with our patients is serving. So it sees the other person simply in need, still competent and whole. The helper is in the position to fill a need, and the helper is in a position to offer support, but you're on equal footing as far as power. And then fixing just sees the other person as broken and the helper as whole. Helper is self-important, but it's not helpful. Okay. So I'm going to go through this quickly, but normal grief, there is resolution. I think the DSM-4 is slowly starting to renegotiate or rework their definitions of grief, normal grief versus complicated grief. It is important to think of complicated grief because complicated grief does come with some detrimental things as far as health of our caregivers or health of our patients. Risk factors for complicated grief. So if you have anybody who's had the death of a child, who's in kind of a codependent relationship with the deceased, you can see lifestyle rigidity. So someone who doesn't really like change or a history of abuse or neglect, these are all things that can put someone at risk for complicated grief. And the reason why it's so important to recognize is because it is associated with higher rates of mortality, dangerous behaviors, impaired immune function, and morbidity. Okay, so let's talk about, particularly in our caregivers of patients with Alzheimer's. This is a study done by Schultz and ended up in the New England Journal of Medicine. You can see it was done in 2003, so it's getting kind of old, but I thought it was a really neat study. They followed 217 in-home caregivers whose recipients died in the course of the REACH study. And the analysis was designed to assess whether caregivers' depressive symptoms improved after the patient was died or institutionalized. So, so the average caregiver age, again, elderly caregivers 65, average patient age was a lot older, 81. Female caregivers predominated the study. It was about half of them were spouses, and you can see the dementia for the patients was pretty severe with their MMSE scores of about 11. And 59% of the caregivers, the majority of them reported like they felt like they were on duty for the whole day. A great majority of them believed that death actually came as a relief to their care recipient. Over 90%. That's pretty astounding, but not necessarily surprising, right? And then 72% of them reported that it was a relief to themselves, so they could admit that it was also a relief to them. So the next study that I'm going to mention is, that I think I'll leave you with, is these different bereavement patterns. And again, these are slightly older studies, but I think they were both very interesting and unique in their own ways, and a nice window on what our caregivers go through and look like after the loss of their loved one. Oh, and the one other thing that I wanted to mention about this New England Journal study is that the caregivers who had their loved ones end up in facilities did not have lower scores of depression after their loved one ended up in a facility. So the burden of depressive symptoms remained high even after their loved one was placed in a facility. Their burden of depressive symptoms came down when their loved ones died. So let me go back to this paper. It talks about the 5 core bereavement patterns. So this is interesting. This was done in caregivers, 185 caregivers of patients with dementia. And they measured the Center for Epidemiologic Study depression score. So it just rates your depression, and the higher numbers are higher symptom burden of depression, depressive symptoms, higher burden of depressive symptoms. And they looked at them before the loss of their loved one, 6 months after their loved one died, and then 18 months after their loved one died. And they noticed that people had different ways of responding, and so they then labeled these different responses. And I thought it was just interesting to see how different people respond. So a good number of their caregivers were actually resilient, and I think I will click on the pointer for this. So you can see that our resilient group of folks, who are about 50%, start off with low depressive symptoms, are doing pretty well. And then after 6 months, after their loved one died, 6 months after, their depressive symptoms are still low, and they remain low. That's one group. And that's luckily the largest group. So a lot of our caregivers are resilient. The next group is the common grief group. So they start off with not too much depression. However, after their loved one dies, 6 months after, they do have an increase in depressive symptoms that then resolves at about 18 months after their loved one dies. And they end up going back down to the level of pre-loss, and they kind of follow along their friends in the resilient group there. Okay. The next group is this chronic grief group, and I think this is a group that is a little worrisome, right? So pre-loss, they're actually doing pretty well. And then 6 months after the loss, look what happens to their depressive symptoms. It goes way up, and then it stays up. So I think that's a group that you have to keep an eye on out there. And they saw that was about 15% of their study population. And then you have your chronic depressed group, where they started off with a high symptom burden. It remained high, and it just remained high. Luckily, that's also a lower number of the population. It's about 8%, right? And then you have this really interesting group who started off with a very high burden of depressive symptoms, and then after their loved one dies, they actually get much better, and they stay better. So again, just illustrating the complexity of our caregivers and how they respond. Same study, and this one actually focused on this scale and measurement focused on grief symptoms. So that first one I want to clarify definitely is depressive symptoms. This one focuses on grief symptoms. So again, not surprising. Oops. You have your resilient population who started off with very few symptoms and very low symptom burden, and it gets lower They obviously did not measure pre-loss grief symptom burden. This is 6 months after loss. And then your depressed improved group, so that group of folks who actually got much better after their loved one died, again, improve a little. And then your common grief group, seen here, again, whose depressive symptoms spike after the loss and then go back down. You can see their grief symptoms kind of mirror that. And then you have your chronic grief group, whose grief symptoms at least do tend to get better over time. So I think that's a little reassuring, but definitely worrisome that their depressive symptom burden goes up. And finally, your chronic depression group, although their symptom burden remained high, their grief symptoms do go down, but never to the level of the common grief, depressed, improved, and resilient groups. And this study, I think, again, is very remarkable in that it followed these people for a long time. So 4 years out, you can see where these groups ended up as well. And again, the resilient group just remains very resilient. And this is now measuring, going back to depression and following that out. And you can kind of see where each group settles out after 4 years. So I'm going to leave you with that. And I think at this time I'm going to take some questions.
Okay. So Brent says there, and this was early on, there's also the interactions between members of a caregiving team. Sometimes you get one or two who believe themselves to be alphas and try to push everyone else around. Dealing with these people in the same way can be slightly more than challenging. And if you could repeat my question.
Absolutely. So Barbara is telling me that Brent brought up early on that there can be some alpha caregivers in a group of caregivers for one patient, and dealing with those folks who kind of push the other caregivers' voices aside and kind of run away with your discussions or conversations or plans of care can be very disruptive. And can be very challenging. And I will tell you that I have no easy answers for that. We come across that a lot in palliative care, and I think, we have various little tricks that we trying to remind them about surrogate decision making, try to really bring the focus back to the patient. But I agree, those people can be incredibly challenging. And I think also sometimes those people have the martyr complex, like, oh, all of these other siblings are trying to kill mom. I'm the only one who's trying to help mom. So you run into these personalities, and I think there's no easy fix for personalities, but my strategy is usually just to try to bring it back to the patient and really try to focus on the patient, and to really try to give some of the other voices in the room a chance to be heard. So I will call on people in family meetings who I haven't heard from and say, I'm interested, Bob, I haven't heard from you, and I just want to give you the opportunity to make sure that I'm hearing your point of view and your voice about what your mom would want in this discussion. So really just trying to be mindful about who's the dominating voice and making sure that some of those other voices have the opportunity, because oftentimes as the clinician, you do have that bit of power to try to moderate a little. But I agree, it's incredibly challenging, and I think we can all come up with a situation that we've been in where we know those people.
And then the Anchorage AHEC, as you were offering some sort of scripts for what to tell people, said that they often tell patient caregivers that there is no harder job on someone than that as a caregiver to a loved one.
Oh, I love that. So Barbara's telling me that the Anchorage AHEC often tells their caregivers that there's no harder job
on someone
than caring
That is a caregiver.
than that as a caregiver for a loved one. And I 100% agree with that statement and telling our caregivers that, because that is something that's so true, right? Like, I can't even imagine providing pericare for my parent right now, right? I mean, I can, I don't like to, but that's a lot of what our caregivers are doing, is providing really intimate, personal, difficult care that you never imagined providing for someone. Yeah. So I definitely love that idea of, again, reminding our caregivers that that we are recognizing in a very meaningful, mindful way that you are doing an incredibly difficult job and you are doing it really well.
Do we have any questions or comments in the room? Well, Billings is typing. It could just be a goodbye, but we'll wait for just a second and then.
Well, while Billings is typing, I just want to say thank you guys so much, because I know you're out there doing the hard work, boots on the ground, and providing care for our caregivers. You're already doing all of this hard work. And I think if you have any recommendations for me as to how I can improve this talk, I would definitely like to hear them, because again, I know that you guys are out there doing the hard work. So if there's things that you'd like to hear about in the future, either areas that I glossed over that you would like to hear more about or know more about, I'm happy to take that feedback. So please do.
So Billings is asking if you have any recommendations for primary caregiver that refuses help.
Yeah, so those folks are very, like Billings is asking if I have any recommendations for primary caregivers that refuse help.
And then added, and refuses to see the patient with dementia with new limitations.
And refuses to see the patient with dementia with new limitations. So I would just, yeah, again, no easy answers. I would try to suss out if that person is struggling with caregiving. If they are kind of happy in their situation and coping well, then I think I would let it slide. I think most of and let them meet them where they're at. I think what you're asking though is that you're seeing these people who really could benefit from help and are at high risk of caregiver burnout and just refusing to see that and refusing to accept any recommendations for help. And their coping strategy might be denial at that point, or what we see as denial. So I think, again, those are just really difficult situations. I would continue to offer the resources because that's a very internal switch that needs to be flipped, right? We are not going to make these people see that they need help. That is something that happens to each one of us internally, is that something happens and we see that we need the help, right? So I would say that unfortunately is not in our hands as caregivers. I mean, as clinicians, we are not the ones to make these people see that they need help. Something happens in their situation that makes them see that they need help. We can continue to offer and we can continue to normalize that it's completely normal to accept help, to get help, that their life might be better with the help, and again, just offer. But that might be something that's out of our hands, and the best we can do is just continue to be supportive and offer the help, right? Because again, it's the caregiver that needs to recognize. The other thing you could try, although I think that this person that you're talking about is not going to necessarily accept this, is the time trials like I talked about. How about we give this a try for 2 weeks, for 4 weeks? If you really hate it, or if it's really not working out, we'll stop. But can you just maybe give yourself a chance to experience this, support or this help? Can you imagine yourself or what your life would be like if you had someone coming in to help you? So really just kind of, again, that sort of motivational counseling approach, but also just seeing if they're willing to even do a time trial, because sometimes that's what it takes to flip the switch, is when they actually see what the help looks like. They're like, oh, God, I can't believe that I was living without this. So yeah, those are a couple of strategies. I can't promise that they'll work.
Okay. Thank you very, very much.